Hello there. Today we will be discussing section 2 of 2019 subject periodontology. In this, the question paper is given here on the screen. We will be discussing today short notes. Classify gingival recession. Write the procedure for free gingival autograft. Definition of gingival recession. Exposure of root surface caused by apical shift in the position of gingival margin. Etiology: faulty tooth brushing, tooth malpositioning, friction from soft tissue, gingival inflammation, abnormal frenum attachment, improper restoration and other oral habits. Classification according to Atkin and Sullivan in 1968: shallow narrow, shallow wide, deep narrow, deep wide. And according to Miller, the classification was proposed in 1985. Class 1: marginal tissue recession not extending to mucogingival junction and no loss of interdental soft tissues. Class 2: marginal tissue recession extending to or beyond the mucogingival junction and no loss of soft tissues and interdental bone loss is not there. Class 3: marginal tissue recession extending to or beyond the mucogingival junction and loss of interdental bone and soft tissue is there. And class 4: marginal tissue recession extending to or beyond the mucogingival junction, loss of interdental tissues and malpositioning of teeth is there. Treatment: surgically treated by pedicle soft tissue graft in which rotational and advanced flap are there, free soft tissue graft, epithelialized graft and subepithelial connective tissue graft. Procedure for free gingival graft. So classical technique is: step 1, preparation of recipient site, extend the incision to approximately twice the desired width of attached gingiva. Step 2, obtaining the graft from donor site. Obtaining a piece of keratinized gingiva approximately the size of recipient size. An ideal thickness of graft should be 1 to 1.5 mm. Step 4, transfer and immobilization of graft. Step 5, protection of the donor site with periodontal pack. Second question, chlorhexidine. Chlorhexidine is considered gold standard in chemical plaque control. Generation of chemical plaque control are first generation, second generation and third generation. In second generation, chlorhexidine is there and in third generation, delmophenol is there. Mechanism of action of chlorhexidine. It is potent antimicrobial and antiseptic that binds strongly to bacterial cell membrane. It is bacteriostatic at low concentration. At a low concentration, it results in increased permeability of the bacteria with leakage of intercellular component including potassium and other components. It bactericidal at high concentration. At high concentration, chlorhexidine causes precipitation of bacterial cytoplasm and ultimately cell death. Uses: it is used as adjunct to oral hygiene and professional prophylaxis, post-surgery including periodontal surgery, root planning, in patient with jaw fixation, in physically and mentally handicapped patient, medically compromised individual, predisposed to oral lesion, high caries risk, recurrent oral ulceration, removable or fixed orthodontic appliances, and in treatment of denture stomatitis. Side effect: brown staining of teeth, temporary loss of taste, bitter taste, burning sensation of mucosa, dryness and soreness of mucosa, epithelial desquamation, discoloration of teeth, tongue and restoration. Products of chlorhexidine that are available: mouth rinse, gel, spray, toothpaste and varnish. Dosage: aqueous solution of 0.2% chlorhexidine, undiluted 10 ml for rinses twice daily for 30 seconds, and another available concentration is 0.1% and 0.12% for 50 ml. Define peri-implantitis and a note on maintenance of implant patient. Peri-implantitis is defined as pathological inflammatory changes that take place in the tissue surrounding a load-bearing implant is known as peri-implantitis. Prevalence: prevalence is between 2 to 10% and it is mostly seen in second and third year of the implant placement. Classification: early, moderate and advanced. In early, pocket depth is greater than or equal to 4 mm. Bleeding on probing is there, suppuration, bone loss, in less than 25% of the implant length. In moderate, pocket depth is greater than or equal to 6 mm, bleeding on probing is there, pus formation is there, bone loss is less than 25% to 50% of the implant length. In advanced case, pocket depth is greater than or equal to 8 mm and bleeding on probing, pus formation is there, bone loss is greater than 50% of the implant length. Clinical feature. Clinical features: probing depth greater than 4 mm, bleeding on probing, pus formation, suppuration and mobility is there. Risk factor: prevalence of periodontal disease, smoking, genetic factors, diabetes mellitus and occlusal overload. Etiology: bacterial infection, biomechanical factors. In biomechanical factors, overloading of implant due to the implant is placed in poor quality of bone. The implant position or load transmission over the implant surface is not uniform. Patient has a pattern of heavy occlusal function as seen in parafunctional habit. The prosthetic superstructure does not fit the implant precisely. Other etiological factors are traumatic surgical procedure, smoking, inadequate amount of bone at placement site, compromised host response. Maintenance of dental implant. Definition: periodic evaluation of implants, surrounding tissue and oral hygiene vital to the long-term success of dental implants. The principle of this method is to detect peri-implant infection as early as possible and to intercept the problem with appropriate therapy. The basis for the system is a regular recall of implant patient and the repeated assessment of following key parameters around each implant: presence of plaque, bleeding tendency of peri-implant tissue, suppuration, presence of peri-implant pocket, radiographic evidence of bone loss. Maintenance treatment procedure is removal of plaque and calculus, behavior modification, oral hygiene instruction, risk factor counseling, scaling and root planning if indicated, and it is done with a plastic instrument. Periodontal surgery if required. Let us see how this is done. If the presence of pus or pocket depth is there that is greater than 4 to 5 mm and slight bone loss is there, then scaling is done along with application of local antiseptic. Then the peri-implant pocket is irrigated with 0.2% chlorhexidine and patient is advised to rinse twice daily with 0.12% chlorhexidine. If pocket depth is greater than 5 mm, radiograph is taken, and if clear evidence of bone loss is there, then a microbiological sample is taken, and if anaerobic flora is there, then antimicrobial is given, and the treatment that is given above, that is scaling and followed with chlorhexidine, irrigation with chlorhexidine. If bone loss destruction has advanced considerably, then surgical intervention is required. The goal is to intercept peri-implant tissue destruction as early as possible. Thank you.